Thank you. And in the morning today, I barely made it today. So I was thinking two things are common. When I was a medical student, few years back, um, not exactly few years, many years back, people were talking about human resources issue. Today, nearly after 3 decades, we are still talking about human resources. And perhaps I thought this has a lot to do with traffic. 30 years earlier, we were talking about traffic. 30 years down the lane, we are talking about traffic. It's not that efforts have not been made, but perhaps efforts have not been commensurate to the issues at hand. In 2016, WHO came up that the biggest stumbling block to achieve universal healthcare is not financing, but the skilling and the human resources required. And this is compounded with the pandemic surge, the new trends which are coming in the digitization. That means our skilling has to be appropriate to the digitization. The skilling has to be appropriate to the climate change agenda as well as aging, which is coming. So today we have this very important seminar with this August gathering. We are talking here about two issues at the higher level: demand and supply and the quality, and how do we deal with the new trends. It's not that ADB has been passive. ADB has been very active. And I thought I'll just sum up what ADB has been doing in this area. If you bucket the issue in three issues: the availability and production, the quality and employability, and the career attractiveness and motivation. So these are the different measures which have been taken by Asian Development Bank for the human resources in different countries through projects, through technical assistance. Like we're talking about expansion of teaching schools like Nishant is doing in Maharashtra. We're talking about equitable distribution, where we realize that if people from rural areas are given more scholarships, they are more likely to work in the rural areas. The upskilling pathways, more on the side of competency based. How do we have curriculum which are more broadened, like the green skilling, as well as the aging, digital, which we are doing in Bangladesh. Accreditation system should be more quality based rather than process based. On the job training, performance linked incentives, and so on. I think to have a deep dive on this, we have a huge August gathering here. And I would like to first introduce Margareta Langis. We call her commonly as Maggie. Maggie, are you there online?
I am, yes. Hello.
Okay, Maggie, let me introduce your profile first. So Maggie is the Nursing and Midwifery Policy Advisor to the WHO Regional Office for Europe in Copenhagen, Denmark. She's a Latvian-born, Canadian-trained nurse, has a bachelor's degree from McGill University for her nursing, University of Toronto, and master's in public health from Paris. Her work at the WHO Regional Office for Europe is involved on the crossroads between health and care workforce, long-term service models, and primary healthcare. Welcome, Maggie, to this session. We have Ian. Now, Ian is the Deputy Dean of Health Professions, Australia National University. He's a clinician, he's an academician, educator, innovator, a patient safety advocate, a Harvard Massey Scholar. He's a currently Deputy Dean of the Health Professions at the ANU. Prior to this, he was the Vice Dean and co-director of academic medical education at Duke NUS Medical School. He's a graduate from King's College with a higher level training in anesthesia. Welcome, Ian, to this panel.
Afternoon, Dinesh. Good morning.
Thank you. Thank you. We have two of our panelists in person. And let me introduce Miss Professor Tran Nuhu Min Han. We'll call her as Professor Tran. She's a Dean of Psychiatry Department, Hugh Medical College, Vietnam. Can I, ma'am, request you to please come on the stage? Professor Tran, please come on the stage. She holds a medical degree from Hughes University of Medicine and a doctorate in psychiatry from Hanoi Medical University. Her work is focused on teaching undergraduate and postgraduate students in psychiatry, and she's been a principal investigator in many research projects. This also gives me pleasure to invite Professor Sudat S.P. Varnakal Surya, we'll call him as Professor Sudat. He's a PhD and is Dean of Faculty of Nursing, University of Colombo, and the President of Sri Lanka Nurses Association. He's obtained his BSc Honours degree and from Sri Lanka, Master's degree from Adelaide University, Australia, with a PhD, and his works are on occupational health, work ergonomics, health of nurses, including staff burnout. Welcome, Professor Sudat, to the stage. Since we're just running behind the schedule, I'll directly go away to the questions, and perhaps my first question, we can start from Ian. Ian, the first round of discussion will feature on the demand and supply challenges and what opportunities we can have from Asia Pacific region. So we have heard right now the demand and supply issues. Can we understand from your perspective of working in this sector of what are the challenges and the opportunities being made up for human resources gap, their quality, their regulation? We have heard issues about hiring, then retaining them, and also on the migration. So your perspective to start the discussion. Over to you, Ian. Thank you. Ian, I think you're on mute.
Thank you, Dinesh, and apologies for not being able to be there in person with you. We've got an awful lot on in Canberra this week. I think in short, sort of health professionals education really has to step up in this unique critical world challenge in terms of health professions shortages. And I think I would sort of break things down into three key areas. We've got to have the right people, we've got to have the right programs, and we've got to have the right places. And when I mean people, I mean, I think if we also need to understand the roles, and more importantly, not just so much their roles, but the value proposition of the different species of health professionals as we look across the whole health and social care industry, because there's an intimate relationship between healthcare and social care. A lot of hospitals around the world are full of people who can't get into social care because of a lack of appropriate social care facilities. So I really do think we should be looking at health and social care as a sort of super industry, so to speak. And I think in terms of the challenges then, I think we need to understand what high-performing professionals look like. And for a very long time, we've focused on knowledge and skills, which are all very well and all very important. But in my previous experience as a regulator, when you actually look at how and where professionals cause harm to patients and systems, it's usually, yes, some of it is through knowledge and skills, but 2/3 of the problems, and often the most serious problems, are around values, behaviors, and what I would call the higher order professional capabilities. And so I think systems that are moving forward in this area of developing professional identity, of developing high-level interprofessional capabilities, such as the ability to work as part of an interprofessional team, a multidisciplinary team, that requires advanced communication capabilities. It's also a skill set that helps with decision-making for patients and their families, and it facilitates a more person-centered healthcare approach. So I really do think in terms of the focus in the programs, it needs to go beyond skills and drills to developing professional identity at its highest level, and that would include these higher order capabilities. In terms of the programs, I mean, there's some fantastic technology, and we'll come back and maybe talk about that later. There's been a massive expansion in the opportunities around simulation, task training, but also with virtual reality and augmented reality, and also advances in technique and pedagogy. So for instance, PBL is a long-established teaching methodology, but more recently, team-based learning, which again is very pertinent, because that's a good way of inculcating students with the ability to work and work collaboratively together. So I think we need to look at our programs and how we create the right learning opportunities for them. And that ultimately then falls on to having the right places. And we can talk about places both in terms of actual physical space, so the hospitals and the academic centres within which they work, but we can also increasingly now talk about virtual space. You know, we're having a conversation, a discussion, a panel discussion in part in a virtual arena. And certainly if COVID taught us anything, that these virtual spaces can actually still, whilst having some constraints, be incredibly useful learning spaces. But I do think that all of the technology and all of the techniques, we mustn't lose sight of what the fundamental priorities here are, which is to produce sufficient, high quality, high performing professionals. And that means they need the right knowledge, it means the right skills, it means they need the right high level professional capabilities, but it also means they need the right values and behaviors to underpin that. And so one of my sort of final points would be the challenge is, how do we move from what has always historically been a very biomedical sciences orientated approach to health professions education to something that is more biopsychosocial in its approach, both in terms of enshrining proper interprofessional learning and multidisciplinary working, but also from a position of values and appropriate behaviours. And one final point I'll just throw in, that means we've got to invest in our educators. It also means we've got to make sure that learners go into safe learning environments within our hospitals. But it also means we've got to work out how we make healthcare careers sustainable over the long term. And that, I'll just close by saying, I think we should equip our learners with the ability to make their careers sustainable. So that means we also need to teach them about protecting themselves against burnout. And so that's about self-care, self-compassion. And these are all skills that certainly in my medical school days, we were not taught the first thing about. So much to do, but optimistic that with an applied effort, we can get there. Back to you, Dinesh.
Thank you, Ian. And we hear very loudly about the 3 Ps you mentioned. And also, I think a very important issue which Ian raised was, is higher education like medicine is a skill or an art? But he talks about that other with the skilling, the attitude, the ethical angle needs to be explored. I think we have open questions. I will request audience to log into your questions, which we will ask as we do with the first round of the questioning from the panelist. Thank you, Ian. And I move to Professor Trahan. Professor, you mentioned you have experience in Vietnam. We realize that Vietnam has been doing a lot of initiatives on collaboration with the leading universities, with the developed nations on upgrading its higher education, medical education. Could you share some insight? What are the strategies, expectations which have come along? Are there any lessons which our developing member countries could face? Over to you, Professor Tran.
Thank you for your question. Good morning, everyone. First of all, I would like to thank ADB for inviting me to this forum. And the Vietnamese government wants the healthcare system to develop and integrate to the healthcare system. And the government strategy for the healthcare system until 2030 are universal health coverage and digital transformation. So to perform the first goal, the government must strengthen primary healthcare system, providing financial investment in primary healthcare and ensure that the healthcare system is safe, comprehensive, integrated, and accessible and affordable to everyone and to everywhere. And besides that, they must also strengthen and develop the human resource, both quality and quantity, by innovation, testing, and ensuring the practice license, forming license testing center according to national, regional, and international standards, and focus on training quality medical staff for multi-nurse, ethnic minor ethnic, and advantage provinces. And they also have policy to promote the medical staff to working there. And I think that promote scientific research and innovation and technology transfer in medicine is also in a strategy. And to support for digital transformation, the Ministry of Health built a legal framework for information technology, and they also building electronic electronic health record, create data, help people, and they also update regularly, accurately, and continuously the health data of the people. And to implement the government health strategy, medical university in Vietnam have been innovating into two areas in curriculum and in technology. And in curriculum, medical university in Vietnam has innovative program, teaching and assessment method toward the training based on competency and population health needs. And we emphasize in outcome-based education, CBL and BPL in teaching, and we also establish student center backward course design to improve the training quality. And we also perform clinical assessment with the form of mini-CX, EPA, and OSCE instead of with oral examination based on record, health record as before. And assessment of theory of MCQ focus on comprehensive, applicable, and analytic question rather than record question. And we also build a university hospital model to close linking the theory and clinical practice. And we also provide multidisciplinary and interdisciplinary training, conducting quality assurance of training program according to national and regional and international standard. And we also participate in university ranking. And in the technology, medical university in Vietnam have built their infrastructure for information technology. They have also new learning management system to upload and download document class material, collecting feedback from students, and discussion forum, administration, assessment, development, online library. And doing so, I think learning environment not limited in classroom, lecture hall and library, but embedded in the virtual space. So the benefits are obvious during the COVID-19 pandemic. Maybe I take much time, so.
Absolutely, I think we hear you loud. You're talking about the university's defined curriculum on the technology side. I love the thing that you said, you introduced rankings, because that invites some kind of competition. We have done in India where rankings among medical colleges actually have spruced them to improve this. And of course, what you mentioned about the multidisciplinary. Sorry, we need to watch the time also, ma'am. Just wanted to say one thing, that what medical education makes it difficult is, it's not only education, but also the on-the-job dealing with patients. So means you have a functional hospital settings along with it, and that makes it challenging. And this brings me to the next question from Professor Sudat, and it's a question which not many people will be able to answer, but I will challenge it to him. Allied healthcare plays a crucial role in healthcare systems, bridging the gap between the emergencies and the patient care. How can we ensure that the paramedic training and certification, which is both in the college as well as in the field, achieves international standards, especially in the resource-constrained settings in Asia and the Pacific? Thank you.
Thank you. Very good morning to everyone. Thank you, ADB, for this invitation. Yes, the paramedics, the term paramedics we use interchangeably with this allied health professions. At the beginning of the 21st century, I think there are only few paramedical specialties, but thereafter there are a large number of around 100 paramedical or allied health professions. The thing is, the purpose or the goal or the objective of all paramedical and also other healthcare professionals is same, because we are trying to give the benefits to the client or our health consumer. Therefore, whatever the degree program, diploma or certificate, they should maintain the standard, because they are dealing with the human being. Therefore, they cannot make any errors, mistakes. Therefore, they need to maintain the standard. Therefore, wherever the country you are giving the education, definitely you need to maintain international level standards, and also there should be proper regulation with the, especially human involvement is there. There should be proper regulation and ethical coverage, and there should be regulatory bodies, especially when you come to healthcare professions, medical and nursing, midwifery, and the most leading healthcare professions. They have regulatory bodies. Then all the healthcare professionals, they should get the accreditation training. In order to maintain the standard, all healthcare professionals, they are accredited to different professional bodies, and they are maintaining the standard and also quality assurance things. But there are few healthcare professional, allied health professional, they don't have the proper mechanisms like regulatory bodies currently. But I had involved in dealing with healthcare professional training, not only nursing. I'm a nursing person, but I had involved training and preparing curriculum in the healthcare professionals in other degree programs in particular some universities. So I know that there are areas, in order to maintain the standard, we always follow international guideline while we are preparing the curriculum. And also, in addition, the regulatory body in the country, you have to get accreditation, especially nursing, midwifery, and other pharmacy related degree programs or training courses they need to have. So as you mentioned that resource constraint area like Asian countries, of course we need to think about the available resources, because the Asia Pacific countries are the most conducive environment for trained healthcare professionals than other Western countries, because we have enough patients, populations, and they are not much concerned about that rights, and you can easily get the training and give the exposure to these people, the trainees in the healthcare system. Of course, we have some material resource constraint, but if you prioritize the needs or training needs, then you can give the priority and maintain that issue. In addition, we need to go for some, we have to adhere to some kind of creative, innovative way of handling the education, because sometimes there are areas you have more healthcare professional trained, but they have no jobs. But there are many areas you have shortage, but you don't have to. You see that there's a great shortage of healthcare professionals in the world at the moment. That there are some prediction from the WHO, around 18,000 healthcare professionals, additional healthcare professional need in by the year 2030. Therefore, there should be preparation from each and every country to prepare the healthcare professionals, especially to cater the future demands in the world. There's a big issue in the Western area now. They have bigger problem they're experiencing at the moment is healthcare professional shortage. Therefore, there are different programs they have introduced to recruit from the developing countries to get the people from health professional from developing countries. But there are some ethical issues again. We have to address all these things. WHO has already given some ethical guideline for international recruitment. I think if you adhere to those things, we can solve the problem in a very win-win manner. Right.
Thank you, Professor Sudat. We hear you loudly about the regulation, about the maldistribution of skills in different sectors within the health, and of course, the issuing of guidelines and perhaps also following the guidelines. And I'm sure, I think we'd like the audience to come forward. A very important issue Professor Sudat mentioned about migration. How do you see migration among the health services? If resources go out from the country, how do you feel that? Is that a loss? Is it a brain drain? Or they come back and actually do a multiplier effect? Hang on to your questions. We are getting a lot of questions here. Please keep on putting till I go to the next from the WHO. Maggie, you will have the last word in the first round. So you were mentioned in every speaker here about WHO guidelines. Tell us something. We have heard a clear vision has come out from nursing and midwifery education. Can you comment, listening to what issues we have raised today, how do these address, especially the issue of regulation, accreditation, and migration? Over to you, Maggie. Thank you.
Thank you, Dinesh, and thank you to the ADB for inviting me to join you for this opportunity, even if it is 3 o'clock in the morning here in Copenhagen. So it's a real pleasure to join your group. I'm sorry I'm not there in person. As you said, Dinesh, my specific focus is actually on nursing. At WHO, there has been a reinforced focus on nursing, and this is sort of for two reasons. One is this represents 90% of health system contacts with patients, nurses. And that contact is one that calibrates or brings together immediate medical and health needs, but also social needs. And as Professor Sudas said, it also, this profession also works very closely with allied health professionals, and often even the people who are in charge of managing the nursing profession are also responsible for a very big multidisciplinary team. But it's also about focusing on women in work, because this profession is 90% women. And it's also about focusing on decent work for this profession. We cannot see the workforce in isolation from some of the inequalities that play out in our society. And indeed, we have a lot of guidance at WHO, but the guidance that I work with are the global strategic directions on nursing and midwifery that were endorsed in 2020 by all ministers of health that convened in 2020 and endorsed the resolution 74.15. And this resolution and the accompanying guidance on the global strategic directions on nursing and midwifery are really based on the first ever State of the World's Nursing report that showed that we need to focus on 4 different areas in strengthening nursing and midwifery to ensure that the glue of our health systems, that front line to work, front line to our health systems, is at the highest level. And that we have to approach it not just with education, but with leadership, service delivery design, and decent work. So we have to take a bundled approach. It will not be sufficient for us to approach this just through education without approaching the other areas. And as I said, that social context in which nurses work. So we see, and I hear from my colleagues in Manila who work in WHO, that your region is still very much lacking in some of the quality assurance mechanisms for nurses and midwives. And I have a colleague at your Manila office that that can support countries in this way, but also and what we mean by this, for these quality assurance is really the working conditions and the education. So I agree absolutely with you, Ian, about the competencies, and they're very important. And we still haven't cracked the nut on how to regulate competencies, not skills. And we have to move in that direction. But we also have to focus a lot more on regulating the environment and the system processes that generate these people. So for nurses and midwives, based on that State of the World's Nursing report, it means really designing education programs to be competency-based and apply learning design, effective learning design. So our faculty are properly trained in the best pedagogical models, that our curricula, the quality and content is there, and the protection of mentorship and practice experiences as much as theory experiences. So it's less about the people, but it's about the systems around them that need to be regulated. And also, as Ian mentioned, and as our previous speakers mentioned, the multidisciplinarity is important. So the interprofessional education and the intercollaborative processes need to be supported in our countries. And the final thing I'll say is that the regulation of pay and hours of work, the ratios of health workers to patients, and the well-being supports that create a continuous learning environment, a safe place to practice, are extremely important here. And I want to bring to your attention the gender pay gap report that came out with ILO and WHO that really showed that the health sector has a gender pay gap twice that of other sectors. And this has an effect on how the workforce is going to perform. They're going to leave the workforce, and unfortunately, because in our region, 63% are nurses and midwives, that is a very, very critical thing. So I'm going to stop here, and over to you, Dinesh.
Well, thank you, Maggie, so much. I think we hear it loudly about the regulation, the competencies approach, which we're advocating to the WHO, the effective learning design, and of course, the factor of remuneration. 63, I think in Asia and Pacific, it would be 90% women. And if it's a gap of their remuneration, that's an issue which we must tackle along with the gender parity. Hear it loud about the systems process. I think we are getting a lot of questions from the audience, and Rudy has already posted a question on public-private challenges, and I think maybe the second round, if Mekong, you agree, I'll cut down to just 3 minutes for each speaker, or 2 minutes, because we have lots of questions coming, and I want them to be asking us. And I also believe there's a lot of wisdom in this room. So if anybody feels they will also need to chip in with an answer, please feel free. I will take this liberty from Mekong to go to them and seek their opinion wherever possible. But coming back to the panelists again, and it's again for 2 minutes, Ian, we hear it loud about digitization. We all agree digitization is going to come up. What about artificial intelligence? How are we prepared? How is medical education going to change once AI comes? 2 minutes. Over to you, Ian. Thanks.
Yeah, I mean, I think probably it comes with a big health warning. I mean, I think AI is clearly going to be a very disruptive innovation across not only healthcare in general, but healthcare education as well. Obviously, ChatGPT's been hailed as the new frontier, and there are many other working platforms in this space. But it's obviously sort of disrupting established assessment techniques and technologies. There's a lot of concern around plagiarism and that sort of thing, but also there's an awful lot of weakness to it, because these are generative predictive algorithms, and they make up references. They also they're based on probability and statistical prediction of the next word. So I think first, foremost, and centrally, we need to teach both our students and our faculty the fundamental strengths of these new techniques and technologies, but also, perhaps more importantly, their limitations and their weaknesses. And I think that's a critical part of both educating the faculty, but also helping students understand how to do things. I do also think, though, that in terms of assessment, and particularly, healthcare has always historically focused very much on actual individual performance, either through oral presentation or through clinical presentation. And I do think that actually will protect against some of those challenges going forward. I mean, I think talking more generally about technology and AI in particular, one of my golden mantras is only ever use the level of fidelity in terms of technology or simulation required to achieve your learning outcomes. And I think it does also offer another unique benefit, which is simulation in particular moves the steep and dangerous part of the learning curve away from patients, the system, and the service. However, it will never fully replace and may actually only be an adjunct to high quality clinical experience, which again goes back to my 3 Ps. You've got to have the right clinical educators. You've also got to have the right students coming in. You've got to have the right programs using proven and adaptive learning techniques. And you've also got to have the right places, both in terms of regulated and culturally acceptable behaviour. So I think it's the whole package we've got to look at. Technology can augment, but it won't ever replace.
Absolutely, and thank you so much. So we all hear out that we will need to embrace technology. AI is one of them. But of course, this innovation will need to follow regulation. It needs to be properly designed and culturally adaptive to be effective. I'll go to now Professor Trahan. COVID showed us the case of how important is the mental health well-being. And it was not effective only for the people, but also for the health staff. What measures do you think Vietnam and other countries are taking to bridge the gap of mental health professionals, and how can we improve their service delivery or make them part of the mainstream health services? Thank you.
Oh, thank you for your practical question. Yeah, as you know, term COVID-19 pandemic, the prevalence of mental disorder has increasing, not in population, not in adult, but in the children and adolescent. And 2 days ago, when I talked to teacher from Philippines, they told me that there are some adolescents in their school committed suicide. Oh, I think it's also happened in Vietnam and other countries. So it's a severe problem. And I don't know how about in other countries, but in our country, in Vietnam, the psychiatrists and medical staff working in mental health system is not enough. And according to report of WHO, the psychiatrists per 100,000 population is only 0.72. So the human resource working in mental health system is not only in lacking, but also an even distribution in different regions in our country. And the psychiatrists concentrated mainly in big city and planned area, and in mountainous area and remote area, almost no psychiatrists. And not only psychiatrists, but also staff working in a mental health system is lacking, such as psychotherapists, social worker, and specialists, teaching specialists. And even the psychotherapists in public health sector are not assigned occupational title cost and cost in payroll. So therefore, to solve human resources and integrate mental health system into general models such as we transform the service delivery model such as daycare, based care, community-based care, interdisciplinary, multidisciplinary care, and biopsychosocial care. So thank you.
Thank you. I think you really nailed it, saying that if the mental health services need to be community-based and move towards multi-sectoral. I think that's amazing. I have getting a lot of questions, and I think, and there are voting going on for those questions to be taken. Quickly to Professor Sudat. Again, a tricky question to you. How do you handle migration of healthcare workers?
International migration is, you have to take a positive and negative aspect of the two concepts. What you have to do, you have to mitigate the negative effect of international migration, and also you have to maximize the positive effect of international migration. When you come to source country, there are some benefits you are getting, foreign revenues or other benefits and exposure. There are health professionals to the international well-developed countries, as well as the destination countries. They are getting health care resources, trained people to work in their countries. Therefore, there should be benefits to both countries. There are some suggestions made by WHO even. The destination countries, those who are taking healthcare professionals from the developing countries, they should facilitate support for developing the healthcare professional in these developing countries by investing money and training and giving exposures to and training to the people, those who are coming. When they go back, they use that knowledge and skills in that country. Then again, when you are using the minimizing the negative effect, you have to plan and train people. In addition to the requirement of the country, you should prepare people for international. You can cater for the international market, then you can get some benefits from that side. Again, when you come to the destination countries, they have that ethical recruitment. They have to maintain the ethical recruitment, especially adhering to the international guideline and ethical codes introduced by the international organization WHO. And also, they should look after these people and train these people, expose these people, and give them, strengthen these people during their stay in their particular country. There should be bilateral agreement, regional level, global level, as well as, because this is a world crisis at the moment. 18 million additional people you need to cater for this big issue.
Thank you, Professor. So that we hear it loud, 80 million health professionals requires in the next decade, and we need to work together as a family. I will just extrapolate this question from different countries to what Rudy asked about private and public, but I'll come back to that in the question session. Maggie, we have lots of questions coming on environmental regulations, lots of questions on clean climate and health action. How is WHO, the curriculum, the nursing sector getting prepared to the climate crisis in the health? How are we sensitizing our people? Any insights on that?
Well, I have to come clean and say that we haven't assessed how our curriculum are incorporating this, but it's very clear that when it comes to nursing, because that's what I've been focusing on, our nurses, but I would, okay, fair enough to say all of our health workforces are, all of our health workforce are far too familiar with the impacts of climate change. So where they provide interventions, nurses are really trusted by their communities to do so and see the effect that climate change has on their families and the communities. So it's really important that using their lens of health equity and advocacy and strengthening and supporting this workforce through the global strategic directions on nursing midwifery, we can empower this workforce to really make meaningful changes and innovative changes. And we're already seeing, what we are seeing in our region is that nurses are transforming delivery of healthcare pathways. So providing better experiences for patients that have lower carbon care. So we're seeing greener theaters reoriented and that are reducing the use of plastics and using more reusable equipment. We're hearing about Entonox gas and delivery suites being replaced by lower carbon alternatives. Okay, so these are some of the innovations that we're hearing about from our government chief nursing officers that I meet, that their nurses are really connecting with. This is a much more interesting way of practicing, actually, where they know that they can have some impact on the environment. Even preventing incontinence, which is a very basic nursing skill. When it takes 500 years to decompose one continence pad, right? And 12 million are used in the UK. The role of a nurse in preventing incontinence has that impact on climate change, but also changing the pre-assessment to virtual, right? And reducing patient journeys using traffic, using cars, right? So in the UK, we saw a reduction of 17,000 patient journeys because an assessment could be done virtually by nurses, or using electronic bicycles. In Tajikistan and our Central Asian countries, they're using bicycles instead of cars to get to work. So I think there are many interventions that all of our health professionals can take, but as that front line that's sort of managing the orders and the requests by other health professionals to keep our patients safe, nurses can also keep the environment clean. And all of our health workforce sees the benefit for that, as climate change is definitely influencing our health and well-being and increasing the burden on our health workforce.
Absolutely, Maggie. Thank you. In fact, just to say that, Asian Development Bank has been working on climate and health, and just some figures. Health contributes more than 5.3% of the global emissions, twice the aviation sector, which is being talked so much about. If healthcare was a country, it would have been the 5th largest emitter of carbon dioxide. We have hospitals working day and night. We have, as Maggie mentioned, the anesthetic gases are 2,500 times more carboniferous than carbon dioxide. And when she talks about green theaters, green skilling, bio-waste management, I think this is where we are heading towards. And we have some very interesting questions, but let me go to Ian first. Ian, there's a question which is talking about, when we are talking about different countries, how do you integrate the standards of education and healthcare among different countries? When the people migrate, how do you regulate that? How do you ensure that healthcare is provided safe and efficiently? And just to extra this, the question says, can there be a mutual recognition of skills and healthcare professionals when they work abroad? Ian.
I think that would be a very noble goal and a very noble sentiment. I think in practice it's really difficult for all the reasons that we've been talking about for the last hour or so. I mean, again, I think you might be able to use sort of equivalence if you introduce more national or standardized testing. But again, the problem with any and all of these things is that they're often, and I would extend this to the very practice of within healthcare disciplines, they are very socio-culturally determined and dependent. And so I think that's another part of just the fundamental reality of the custom and practice across any discipline will be different in different countries. So I've had the privilege of working in the UK, America, Singapore, and now Australia. I've also done a fair bit of work in sub-Saharan Africa as well. And although the knowledge might be comparable and some of the skills, which are often driven by the economic availability of equipment or facilities. And so people are often very frugal and creative in their problem solving. And so I think everywhere is different, but particularly in the context of socio-cultural terms, so beliefs and values, both at a societal level and then also within a professional level, is also where I think things can diverge. And from my own experience as a medical professional regulator, we often found that it wasn't that the knowledge and skills weren't there, they often were. It was just the unique socio-cultural expectations, both of patients and their families, and also the practitioner were either different or non-aligned. And so I think fundamentally, the hope of a universal passport in terms of health professions migration, I think fundamentally is a noble idea, but a very difficult one to deliver on. But I do also think that it also goes back to the point that Maggie was making about the fundamental importance of having robust quality assurance and regulatory systems in place in all jurisdictions, and that there are some fundamental principles that you could employ in those terms that would drive that sort of convergence over time, which I think would be welcome and would facilitate both migration and interoperability of different health professionals around the world. I think the one final point I would say is we also have a problem that we have a current established notion of what the right species are, and some of the work that we've been doing at the new National Centre for Health Workforce Studies is looking at other niches in terms of role development, role migration, role substitution, and maybe we need other practitioners being developed within the workforce too.
Thank you, Ian. So Ian feels that there's still a long way to go for what he calls as interoperability of species from different countries for the health sector, if I can put it that. Though interoperability of digital system is going much ahead, right? So he feels there is still a time gap when we can have a universal passport for health workers acceptable across the world. But moving on to the question which Rudy had posted, and so that's only 1 minute for you. You're talking about different countries' migration. What about within a country where people perceive that the private sector people go for having a better attractive career, and thereby the public sector gets ignored? Any views on that?
Right. When you come to you're asking from my country. Sure. Yes. Right. In Sri Lanka, there is no private sector private involvement in healthcare professional development or training or education at the moment, but there are some initiatives taken by the government because of this shortage in healthcare professionals. But at the beginning, the last 3-5 decades, health professionals are prepared, they're developed by the state sector universities and colleges and training institutions. Therefore, they maintain the standard all the time. But when you come to private sector, nowadays, there are certain other international universities, they have come to the country and they have established new programs and they are maintaining standard. But government has prepared to give opportunity for these people from private sector people to develop healthcare professionals. That is, at the moment, it is ongoing process.
Perfect, thanks. Anybody from the audience would like to take this question on public-private gap and how it's being perceived? Anyone with their wisdom? Otherwise, I'll go to Nishant. I don't give him a choice. All right, Nishant, would you like to say a few comments before?
Thank you, Dinesh, for giving this opportunity, which was well planned in advance, I guess, for me. No, I think private sector will play a very important role because whatever government is doing, there is a limit because the need is very high. You know, as everybody mentioned, we need so many more health professionals in future. So I think in future, if we rely only on the government to produce healthcare professionals, number one, it will not be sufficient. And number two, private sector is anyway very active. So how do we engage more collaboratively rather than keeping them at a distance? I think that is becoming very important. And the second point is that with technology coming into picture, how we can leverage technology more to reduce reliance on human intervention a little bit more. I think that is something which is very important because with artificial intelligence coming, with a lot of new devices coming where through some trained staff, some kind of test and all can be done in the field without being a doctor there. So telemedicine and all these things are playing very important role in improving the skills of the people and reducing the gap between human resource availability and the need for the skills which are required. Thank you, Dinesh.
Thank you so much. And in fact, you know, there's a question on how can telemedicine digitization reduce carbon footprint? And let me answer this question because we did a study in a state in India called Jharkhand, where during the COVID time, there were 500,000 telemedicine consultations. And we realized that 85,000 tons of carbon dioxide was saved. This is going to be published very soon in a paper. And we will share that how telemedicine has co-benefits not only for the patients, for increased healthcare, but also decreasing the carbon footprint. And these are very, very important points which somebody has been raised. Mikong, we have already crossed the time of 10:03. How much time you have for more to sum up? 2 minutes. Okay, we have negotiated 2 minutes. Anybody wants any burning question for us to be asked, which you feel we did not address? I can see there were some questions on regulation. We have tried to answer those. Half a minute to all the 4 panelists. One innovative learning technique which you think is going to be there in the next 2 decades. One innovative thing. I'll start from Ian.
Just one, it would be treat people well.
Sorry?
Treat people well. Behave
treat people well. Treat people well. It's talking about the human relation component.
Create learning cultures that are supportive of learning and nurturing.
Yeah, that's he says it's reinforcing what has to be done. Maggie.
Yeah.
I'm going to say something similar, but I think involving patients and informal carers in our health workers' education is going to be a really important priority for us as professionals to focus on our alliances. As the speaker, as one of the people in the audience said, we need more than our health workers on board.
Perfect. More than being a health worker. Professor Sudat, over to you.
Yes. My main concern is during the past 5 decades, there's a great lack of investment in healthcare professional development, in chronic lack of healthcare professional development investment. Therefore, major concern or a major priority should be invest. That is not my own words, but there was a study in USA. They have carried out a study, 33 countries they involved. They have found that there's a chronic way of not investing properly for health professional education. Health professional mean especially the allied health and nursing. That is a
Absolutely. So one issue has been prioritizing allied education, which of course we keep on talking about doctors and nurses, but healthcare is beyond doctors and nurses. And that's one field which you say. Professor Trahan, 30 seconds. What do you think? One thing would you like to see in the next 2 decades to be implemented?
I think the new technology.
New technology.
Yeah.
Absolutely. So we hear it loud, technology with human angle. We also hear about taking everyone together, not only doctors and nurses, but allied healthcare. You can see on your stage what ADB is trying to achieve through its health human social division, where we are talking about how technologies are going to be part of health education as we proceed. We are talking about simulation, AR, VR, gamified training, e-learning. We will require infrastructure where ADB is ready to support all our DMC countries for the infrastructure and the investment. But never forget, technology can be an important tool, but it's the human beings, which will remain the central theme of the human social division of health and medical education. Thank you so much to the distinguished panelists, and thank you so much for a wonderful audience. Please give our panelists a big hand, please. Thank you so much. Thank you.